Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar Series. Today's topic is HIV and OI respiratory system, and the speaker is Dr. S. Kumar, sir. Dr. S. Kumar has completed Diploma in TB and Respiratory Diseases and MD in General Medicine from MMC. He was associated with GHTM Chennai as RMO and Nodal Officer of the Nodal TB Center. He is a recognized master trainer for NACO and TANSACS as well as PMDT services. He is a co-author for many papers on HIV and TB, and his field of interest includes care and support for HIV and TB patients. We welcome you, sir, for today's session and request you to start the session.
Good afternoon, everyone. Am I audible?
Yes, sir.
Yeah. Thank you, Team iTech, for giving me this excellent opportunity, and thank you, Sweta, for introducing me. And it's nice to be back with our friends on this platform after some time. So the given topic for me is OA in respiratory system. Sweta, you will share the slides?
Yes, sir. Yes.
Yes, thank you. We'll go to the first slide. So the session objectives are introduction and scope, then about the TB, because the opportunistic infections in respiratory system without the tuberculosis, which is a common pulmonary manifestation, it is apt that it has to be given the due importance, even though separately we deal with HIV-TB in different sessions. Then the PCP, already you know, the PCP, then the bacterial pneumonia in this order. Then we have the MAC. When the CD4 comes down very low, we have the MAC. And the tularomycosis, previously known as Penicillium marneffi, a Northeast India fungal infection. The other pathogens with pulmonary manifestation. So this is our plan of our session. Next slide. So what is that we have to know in this? Before the ART era, before 2004, we were treating a lot of HIV patients at the peak of the epidemic. That time, the tuberculosis was, even though we treated tuberculosis, the patient became all right. Because there was no ART, again and again into the community, they developed reinfections and relapses also. And what had happened because of the common, the respiratory system, the airway is exposed to so many of our aerosols, infections. We had a lot of PCP, then we had bacterial pneumonias and so many other infections. And we even had emergencies, respiratory emergencies during our duty days in the form of pneumothorax after a tuberculosis infection, or we can have a PCP, pneumomediastinum, pneumothorax even after a PCP, and acute PCP. People were coming with respiratory failure, ARDS, and we are very busy before the ART era. After the ART, the entire scenario has changed. With the early intervention of ART, now we are able to see more of a sinusitis, upper respiratory infections, sometimes lower respiratory infections in the form of even now the H3N2 swine flu, that influenza virus epidemics are there. There we see these problems. And also the common, the old age, people at aging HIV population, we see other things like COPD and other things, and bronchiectasis, other things. So the entire scenario has changed, and now we have to treat, we have to look into this opportunistic infections respiratory system in a different manner. Then what is the frequent preventable and treatable respiratory? Already you know, the preventable, we are giving more importance to the vaccines and chemoprophylaxis that we are going to see in the ensuing slides. Then the frequent respiratory complaints or cough, dyspnea, pleuritic pain or other things. HIV associated respiratory, mainly upper respiratory infections, sinusitis and bronchitis. The pneumonias are still diagnosed bacterial respiratory infections, and they are still more common than in the normal population. Next slide. So there is a schematic representation in that how the various CD4, you all know the CD4 count, we are now able to do it easily, count and viral load. Previously, we were not having a plan to do frequent CD4 counts. That time, these opportunistic infections were the surrogate markers for finding out the approximate CD4 level. So in that, with that background, they have given a schematic representation where Mycobacterium tuberculosis infection is usually comes around less than 400, but it can come with any CD4 count. The common is less than 400, stage 3, and extrapulmonary stage 4. Then the bacterial pneumonias come when the CD4 is less than 250, and also the suppurative lung and sinus diseases less than 100. Then the PCP or the pneumocystis jirovecii pneumonia less than 200 cells. Usually 90% of the infection PCP comes when the CD4 is less than 200. But with the advent of early intervention, ART intervention, we are not seeing much of PCP cases nowadays. Then the MAC. MAC is a atypical mycobacteria. Mycobacterium avium complex comes when the CD4 is less than 100 or even less than 50. And the viral pneumonia, usually CMV comes with very less than 50 or 100, where you will have a cytomegalovirus lung infection, you can have CMV retinitis, you can have other disseminated cytomegalovirus infections. And other viral pneumonias can occur in any CD4 count. Next slide. So now we have to talk about the Mycobacterium tuberculosis. HIV and TB is important in that, even though it is a separate topic, because of the respiratory, majority of the usually in the normal population, it is like 80-20, 80 pulmonary, 20 extrapulmonary. Whereas in HIV population, it's more of a 60-40, that more extrapulmonary. Next slide. So what is that you have to see in Mycobacterium tuberculosis, that the common cause of death in PLHIV is tuberculosis. So what is that? It is a two-way. Both the HIV, TB can have an impact on the HIV and vice versa. So what happens when the TB comes in HIV? There is a reduced ability to kill the bacteria. So there is this, the cell-mediated immunity is going down. In HIV and TB, what happens? It promotes HIV viral replication and progression to AIDS. So already I told you 80-20 and the 60-40 in the, this is the epidemiology. Next slide. So what is that? The risk of HIV and TB, that adults with latent TB, all know now we have this MAN2 and IGRA test. Those who are exposed to the bacilli develop active TB disease in a normal population is 5 to 50%. Of these 5 to 10% infected develop active TB disease. So the adult totally it is 15% are having latent TB. Of this 5 to 10% develop active TB. So there is a more than 20 times risk of TB in case of HIV co-infection with or without ART. So there are 71,000 TB patients among PLHIV in India 2019. So such a big number of patients. Next slide. So what is the impact? Already told you it's a two-way. It is a vicious circle. So the impact of HIV and TB is that risk of developing TB becomes more higher in PLHIV. I already told you the lifetime risk of average Indian is 10%, whereas every year it is 10% in HIV individuals. So 3 to 10% develop TB, TB infected HIV. So HIV infected TB patients suffer much higher mortality than HIV negative infections because of the other comorbid, other opportunistic infection conditions. So recurrence of TB and long-term post-TB mortality is more in HIV, extremely high. So that is the thing. So what happens on vice versa on the TB on HIV is that the inflammatory response to TB bacilli, that the pro-inflammatory markers, these things have an impact. Even the co-receptor CCR5 and CCCX4 are activated more when the TB is there in HIV and the viral load increases. So rapid progression of the HIV infection. So there will be more AIDS cases. The TB is the commonest OA. So mortality due to TB in AIDS also is very high. So this is a vicious two-way process where the HIV on TB and TB on HIV. So this is so important opportunity infection and respiratory pulmonary problem. Next slide. So what is that manifest TB in relation to immunosuppression? Usually now, because of good ART intervention, we see more of a, what happens is like often resembles post-primary, early phase only. Late phase is very uncommon nowadays, but anyhow, we have to know the difference. The clinical presentation in the early phase of HIV is like a post-primary, like a apical cavity, fibrocavity disease. Sputum will be often positive, and the chest shows cavities in the upper lobes. Whereas in advanced immunosuppression, there will be lower lung field TB, then like in diabetes, then intrathoracic lymph nodes, infrequent cavities, and the sputum smear is negative. But nowadays, because of the molecular test, we are able to diagnose TB even in a late phase also easily. So it is often resembles a primary TB in the form of TB mediastinal lymphadenopathy and other atypical presentation. Next slide. And what is that? The diagnosis in a HIV setting or in ART setting is that we are now have a 4S. We all know. We have every time we talk about the 4S for symptoms. So the research has shown that more than 90% we can easily find out with the 4S symptoms. So every month when the patient comes to the clinic, we are inquiring about the 4S symptoms and fast tracking the patient. So in that, it is in a way the fast tracking helps in minimizing the nosocomial infection. So the 4S already know. In adult, current cough, fever, weight loss, and night sweats. In children, the weight loss is substituted with the poor weight gain, and the night sweats is there substituted with the history of contact with the TB case. So very, very important in children, the history of contact. So here, what is happening? The 4S is there, and the 3 I's are there. So intensified case finding, INH prophylaxis, and air infection control. So that's why fast tracking is very important for the infection control. Intensified case finding with 4S symptoms, and also using the molecular test, nucleic acid amplification test, CBNAT or TrueNAT, because the TrueNAT, next slide, we'll be knowing about the importance of TrueNAT. So here, before that, we are showing the diagnostic algorithm. So this is a crowded slide. Anyhow, we'll just tell you the HIV patient who have presumptive TB means the 4S symptoms. There is a cough, sputum, weight loss, and night sweats. You are going to do a X-ray chest and a smear examination. So whatever it is there, we are going to do upfront. We are going to do CBNAT or TrueNAT. So what is that? In that, CBNAT is a substitute for universal drug sensitivity, UDST, where you are going to find out the first thing, the MTB is going to be diagnosed with the protein. The probe will detect that protein. And the second step, RIF sensitivity or not. So in that way, we are going to find out whether it is drug sensitive TB or drug resistant TB. So if you come to the third line, smear positive, suggestive of TB, smear positive, but X-ray is not suggestive. Suppose it looks normal, it could be endobronchial TB, but smear is negative, but X-ray is suggestive of TB. All these things, the third line shows clinical suspicion of TB. All these things you are going to upfront do a CBNAT, which has revolutionized the diagnostic pattern of HIV TB co-infection. So next slide. So it will be a continuation on the next slide, the same diagnostic algorithm. So what happens? We are going to do a CBNAT. So the CBNAT comes as RIF sensitive, means it is microbiologically on the left-hand side. Please concentrate on the left-hand side. RIF sensitive means microbiologically confirmed TB. In that, one thing is very, very important. We were shown be happy with that. We have to subject the patient for a LPA, line probe assay, so that we can find out the INH mono resistance. So very, very important. Even if the RIF sensitive means should not be happy. Even though we are confirming drug sensitive TB, we have to find out the INH sensitivity, because we have a separate regimen for INH resistant TB. We have a 6 to 9 months with the quinolone. INH is substituted by quinolone. Then RIF indeterminate means we are going to repeat the CBNAT on second sample, or we are going to go for a higher liquid culture or LPA with the higher center. Then suppose if it comes as RIF resistance, we have to send it to the DRTB center, where we are going to do a first line LPA, second line LPA, and find out whether it is mono INH mono or pre-XDR TB or XDR TB, and they are going to start on whether a short course bedaquiline containing shorter MDR regimen, or if it is not possible because of pre-XDR or any other problem, they are going to go give a all oral 18 to 20 months regimen. So in that way, we are diagnosing tuberculosis drug sensitivity as well as drug resistance. An important point here in that, if you are finding out drug sensitive TB, you are going to manage. It is very, very important that we have to prevent the drug resistance. So it is our responsibility in that. the right dose we have to give, the right duration, the time, and the right dose, right duration, and we have to counsel the patient that once the symptoms are gone, don't stop the drug. You have to continue it for a minimum period of 6 months. Right dose, right duration, right time. Even we should not give a chance for the Mycobacterium tuberculosis to develop resistance. So even though if you split and give also, the patient gets cured, but we should not give a chance. So all the drugs to be taken together, and we should address the adverse drug reaction, because ADR is the commonest cause for drug non-adherence. So all these are our responsibilities. So drug sensitive TB means we have to see to that they complete the treatment, and we have a satisfaction that we have prevented drug resistance and we have prevented transmission going across to other community. And even drug reaction is there. Substituting also, always better to avoid a mono drug. In any point of time, always try to give two drugs together, so that even substitution also, we don't end up with a mono drug for few days or something. So these are all minute points you should know. And all presumptive TB cases should be offered HIV counseling testing. And this is an important point. So we all know whenever there is a suspected TB, we are doing the voluntary counseling and testing. Next slide. So this is the diagnostic algorithm we have finished for pulmonary TB. So where you have found out that true not upfront, drug sensitive TB means we have to do a first line pair to find out INH mono. Drug resistant TB, it's referred to the DRTB center to find out the first line single LPA for pre-XDR or XDR, shorter MDR regimen or all oral MDR regimen. So this is in a nutshell. For some coming to extra pulmonary, because this is more common in a HIV setting, CB-NAT is available means we can subject the specimen like crush the lymph node or do a FNSC of the lymph node. There is pus there. You can send it for CB-NAT, pleural fluid. Even though yield is less, you can send for CB-NAT, ascitic fluid, CSF, all these things we can find out the MTB. So CB-NAT is given there. So suppose you are sending to the surgeon for a lymph node excision biopsy, you have to give a note to the surgeon that they are all busy. One portion in normal saline for CB-NAT, one portion normal saline for liquid culture, third portion in formalin for XP. Because in a busy OT setting, they may put all the specimen into the formalin, which may have an impact in the diagnosing. Because of the formalin, if you are going to put it, then the liquid culture and CB-NAT will not get a result. So it is our duty to gently remind the surgeon. So liquid culture is positive, confirm TB. Negative means no TB. So 2 weeks time, the liquid culture will come. So we have now excellent molecular test, and the phenotype also previously LJ medium 90 days for 45 days, another for now. Liquid culture is, even though it's a phenotype test, 2 weeks you can know how the organism is growing or not. You can make use of that. Suppose you don't have a specimen from there, you can have a high clinical suspicion. Whatever the organ, like a bone TB, CNS TB, where you have a high clinical suspicion, other diagnostic tools can be done, like referred to for ultrasound abdomen, for a CT or a MRI of the brain or the bones, and get the specialist opinion. So that is a high index of suspicion in a extrapulmonary, where the organ specific. They may have a severe headache, vomiting, double vision, neck stiffness in a TB meningitis, or it could be other things, like constrictive pericarditis, something like that, breathlessness and pleural effusion. You have more of a breathlessness. So what are the tools for confirmation? You have the, you can go to that this slide. 1 minute. So there are tools are there. CB-NAT, cottage-based nucleic acid amplification technique. There is no big biosafety cabinet is there involved, infrastructure. No need for a big technical expertise. Easily the lab technician can load the system. Detection of resistance via RPOB gene. There are 5 probes are there. First 2 probes to detect the TB, and then the remaining for drug resistance. So within 2 hours, you can get the result in a printout. So it is a very minimal biosafety. So it is excellent tool. Now we have more than 1,000 centers in India of the CB-NAT, and all medical colleges and all the DTDOs have the CB-NAT. More than 1,000 centers are there, and more than 200 TrueNAT centers are there. Then comes the line probe assay. This is nothing but a electrophoretic pattern. Bands will come in the pattern, will come in the paper. So if there is a line probe assay, the detection of any INH resistance is there, bands will come, INH band, band. That is first line LPA. And quinolone and second line injectable band, the second line LPA. So very simple test, 2 to 3 days, you can get the result. So the line probe assay and CBNAT, both are molecular tests where you are not diagnosing the bacilli, but you are diagnosing the genetic material. So easily within a short turnaround time, you are able to diagnose. So this is a excellent thing. Next slide. So this is we have to make use of that. Next slide. So then we have the solid LJ medium, conventionally long duration, this all you know. Then came the BACTEC. Now you have the midget. Next slide. Midget is a liquid culture where the 300 samples you can usually do it, 8 days turnover time. The BACTEC has a more some radioactive material and all, no more favor of midget, Mycobacterium growth indicator tube assay. Large number of specimens can be easily diagnosed with immunofluorescence. That is the midget liquid culture. Next slide. So these are all the facilities you are going to use. So drug sensitive TB follow-up, you are not going to do CBNAT because they can pick up dead bacilli also. So follow-up 2 months, then 6 months, then 12 months, 18 months, 2 years. Up to 2 years is going to follow because the first 2 years only lot of relapses. So first 2 years we are going to follow up with the regular Zeal-Linzer or fluorescent microscope. Next slide. So this is regarding the follow-up. Then you have the next slide. So we have the basic principles, you know. Then use the intensive case finding, CBNAT, then active TB, start the treatment. After 2 weeks, ART, same thing, you know. And the co-trimoxazole prophylaxis should be given to all TB patients because of the stage 3 pulmonary TB or stage 4 extrapulmonary. Minimum 6 months, and after once the CD4 goes up to readings more than 350, we can start the co-trimoxazole, stop the prophylaxis. So this is the basic principle. Next slide. So this is in a nutshell, we have talked about the TB, HIV-TB management because that is the commonest OA which occurs in the respiratory system. That too CD4, any CD4 it occurs. So we have discussed in length about that. Next comes the PCP, or now it's called pneumocystis jirovecii pneumonia. Next slide. So this is a ubiquitous fungus. It is there everywhere. So using ART and PCP have dramatically reduced the number of new cases. So it has brought down dramatically. What is the right word for that? Because the ART is a miracle which has given such a quality of life to the ART patients, as longevity also. So PCP occurs in full-blown AIDS. So AIDS-defining illness. Stage 4 disease, 20 to 30%, 20 to 40% associated mortality even after treatment. So a lot of this advanced immunosuppression, late diagnosis, mortality is more even after 21 days of PCP treatment. PCP occurs when CD4 is less than 200. That was 90%. Already I told you, almost more than 90% occurs when the CD4 is less than 2. So healthy children develop antibodies to jirovecii by 2 to 4 years. So it is already present in our respiratory tract. It's a normal common solve, but it turns pathognomonic in a reduced immunocompromised state. Next slide. So the PCP, how it presents. So in adults, the dyspnea is the main symptom. This is the key presenting feature of PCP. So it is it initially it occurs on exertion, but later on rest also. So this pulse oximeter we were using before that ART also, when only not everyone was carrying that, it was in the ICU or in the ward. Whenever a PCP patient comes, we ask them to walk for 10 feet, come back and see the oxygen saturation, it will dip down 10%. So that was one of the bedside tests we were doing before the ART era. So dyspnea is there, low blood oxygen levels, hypoxemia, and the dry cough, tachypnea. So main thing is that the symptoms will be disproportionate to the sign. When you do auscultate, there will not be much of a signs are there, but they will be very distinct. So that was the hallmark of the PCP. The symptoms will be disproportionate to the signs. So chest X-ray, classical ground glass will be there. That is more pronounced in the lower lung zones. Intrathoracic lymph nodes are not, usually they are not a common feature. Usually what we say, butterfly appearance. From the hilum, there will be a butterfly appearance like a opacity. Next slide. So in children, what is the tachypnea, dyspnea, cyanosis, sudden onset of fever, Auscultation, already I told you, less specific. The chest X-ray, so diffuse ground glare, opacity, or reticular nodular. So it could be ubiquitous. Anything can be there. Mild cases, parenchymal infiltrates predominantly perialar, progressing to peripherally to reach the apical portions of the lung. So usually you don't see a cavity or biliary lesion. Pneumothorax and mediastinum or pneumomediastinum seen. So whenever you see a cavity or a pleural effusion, we have to think of one thing, any coexisting pathology like a tuberculosis or a fungal lung or an nocardia like that. So whenever a PCP comes, effusion and cavity, usually we have to be careful in that. There could be other co-pathogens also. So tachypnea in children is defined as more than 60 per minute in less than 2 months, when 2 to 12 months more than 50, like that, 1 to 5 years more than 40. So any child 1 to 5 or respiratory rate is more than 40, we have to admit the child and see radiologically, see and any clinical examination and more search for any respiratory pathogens. Older than respirate more than 13 older children also sign for a red flag sign. Next slide. So this is in children. So how to diagnose? Diagnosis is more a clinical. Blood tests and chest are not pathognomonic PCV. On X-ray you can take the hypoxemia and the lesser signs, more symptoms, histopathologic or site of demonstrated organism, tissue, ball fluid or induced sputums are required, but these are all very needs more technical expertise and a tertiary care center. Next slide. So PCP is more of a clinical diagnosis. So this is a presumptive diagnosis. The proof of the pudding is the eating. If you do give high dose cotrimoxazole and sometimes steroids, dramatic improvement in the patient. So presence of clinical symptoms, low CD4 count, presence of oral candida. So oral candidiasis is a surrogate market for PCP because of the advanced immunosuppression. Usually we see OC also in a PCP. Suboptimal prophylaxis. You take a history, the cotrimoxazole prophylaxis would not be adherent. That could be a good important history in the past. And PO2 can be used to grade the severity like 60, 80 like that. Chest X-ray may support the diagnosis. And LDH level is high because LDH is a sign of tissue destruction, inflammation. We were using it as a poor man indicator, like in COVID also we're using LDH, in hepatitis also we're using LDH. Next slide. So definitive diagnosis, so it's a presumptive diagnosis. Definitive is mainly by demonstrating the organism. But how to do about it? Sputum induction is difficult. Two things. If you are going to do it in an open place, they may infect the healthcare workers with hypertonic saline or nebulization. Coexisting TB may be spread, or other things can spread to the normal population or healthcare. So it's very, very careful. You have to do in a separate place. If you are going to do a sputum induction, sometimes they may have a pneumothorax in an active PCP. So it may complicate. So we have to be very careful. BAL is okay. We are going to do a fiber optic bronchoscope. It is available, and a transbronchial lung biopsy can clinch the diagnosis. And the PCR is there, but it is not available everywhere, where PCR can be an alternative method for diagnosing PCP. Next slide. So very often difficult to obtain. So it can be collected. So it's risky. Then all material carved out is collected and diluted with equal volume of sterile water, and you should use a specific strain. It's difficult to induce sputum in children. Next slide. So this is regarding the lab diagnosis. So we have to give treatment. So prophylaxis is very, very important particularly in the respiratory system. So first prophylaxis is the primary prophylaxis for CD4 is less than 350, WHO staging 3 and 4 we are going to give to prevent PCP. Then we have to prevent the incidence of malaria, minor diarrheal disorders, minor respiratory disorders, and toxo. All these 5 will be prevented by a simple cotrimoxazole. Secondary, all the persons who have completed PCP have to do a secondary prophylaxis, minimum period of 6 months. And regimen, 1 double strength tablet each day or 2 single strength. For a benefit of junior colleagues, you can remember like that. Every 4 kg, 1 tablet. Suppose a person weighs 48 kg, you have to give, that was the therapeutic dose. I'm sorry. Therapeutic dose is 48 means 12 tablets in a day in divided dose. Whereas in a prophylaxis, it is for all, it is only 1 double strength tablet. So this is regarding the treatment. I am telling you every 4 kg, 1 double strength tablet. When the CD4 count is, single strength tablet. When CD4 count is more than 350, we can stop the PCP prophylaxis. Next slide. Okay. So commencing primary CPT, already I've told you, timing the initial cotrimoxazole, like initiating ART, start cotrimoxazole first, then start ART after tolerated, patients completed preparedness phase of count, so that we can know any adverse drug reaction. We can find out. Also, there is a preparedness counseling is taken place. So ART is not an emergency in all the sittings. Next slide. So then what is that? Commencing secondaries, having completed treatment, immediately you have to start them. Dosage of cotrimoxazole, 1 double strength tablet, 2 single strength tablets. Next slide. These are all the slides for completion. We are continuing. So cotrimoxazole for pregnant and breastfeeding women, it can be continued. There is no toxicity. Breastfeeding women also should continue CPT. Patient allergic to sulfa means you can give dapsone. Cotrimoxazole decentration may be attempted, but it is very risky. We have to go. Sometimes they may develop a Steven Johnson also. We have to be very careful. Next slide. So it should be done in only monitoring. There is no specific monitoring for cotrimoxazole prophylaxis. Rarely they go for a blood dyscrasis, very rarely. So we can. It's not very threatening. So discontinuation of cotrimoxazole, the CD4 reaches more than 350 on 2 occasions. Next slide. So these are all about the cotrimoxazole. So how to go about the desensitization? It is there in the tabular column. You can take it a handout, and it is but very risky. 2 ml, 4 ml. So very, very careful. So it's better to do it in a advanced setting. Next slide. Where multidisciplinary approach is there. So prophylaxis, all HIV exposed children, all you know, from 6 weeks of age or first encounter with services. When to discontinue, HIV has been reliably excluded by 18 months. You can discontinue all HIV infants up to 5 years of age, regardless of WHO stage or CD4 4%. At 5 years of age, critical immunologic factors confirm restoration of the immune system for more than 6 months. Then you can stop. Next slide. So these are all the things we have to know. How to start, when to start cotrimoxazole in a children. All children more than 5 years, or like adult. So secondary purpose. All these are same thing as an adult. Next slide. So these are the indications for. So dose is less than 5 kg. We have to do a 2.5 ml or child tablet, 1 tablet, 5 to 10, like that. You have to strictly and accurately give the cotrimoxazole prophylaxis, PCP prophylaxis. Next slide. So management of PCP, already I told you that mild to moderate cases, I told you 15 to 20 mg of trimethoprim. That comes to every 4 kg, 1 single strength tablet. Every 4 kg, it will be 1 kg means 15. So yeah, 4 means 80 milligram trimethoprim. So like that, you have to give a stiff dose of cotrimoxazole, high dose. And moderate to severe also, same thing. It can be IV preparations are there. You can give that. And the alternate is, they are not able to give cotrimoxazole, you can give dapsone or primaquine or atavacran, which are not easily available. Pentamidine IV or pentamidine or primaquine plus clindamycin. Usually those days when with the cotrimoxazole, we didn't get the expected response. Usually we add primaquine or clindamycin as an add-on drug and see if there is any resistance. So the indications are PaO2 is less than 70 means then we have to give high dose of cotrimoxazole, prednisolone, high dose 40 mg, then 1 milligram like that, and taper the dose. So minimum period of 21 days PCP cotrimoxazole treatment, and steroids up to the clinician's judgment. So whenever there is a severe inflammation, you have to give, or hypoxemia, you have to give along with the cotrimoxazole steroid. Then next slide. This is the management of PCP. The duration of treatment is minimum 21 days. You have to give, then you can take a decision after that and continue with the secondary prophylaxis. And the thing is that after 21 days, you can start ART, because PCP during the start ART means there will be immune reconstitution, flare up of the disease, and you lose the patient. So you have to be very careful. Next slide. So what is that? You have to see that high dose cotrimoxazole, PCP also same thing. You have to extrapolate and give the it's a ready reckoner, you can give a high dose cotrimoxazole as a treatment for PCP. Next slide. So now comes, we have common two things we have discussed, the tuberculosis and then the pneumocystis jirovecii pneumonia. Now coming to the bacterial pneumonia, which is the third most common respiratory opportunistic infection. Next slide. What is that? The TB, PCP, pneumonia. This is the three types. So the incidence of pneumonia increases by 6 times in untreated HIV population than the normal population. Next slide. So what are the risk factors? Low CD4 count, lack of ART or intermittent use, irregular use, tobacco, alcohol, injection, IV drug use, chronic viral hepatitis, COPD, already decompensated lung, malignancy, renal insufficiency, congestive heart failure, underlying pulmonary disease like bronchiectasis, chronic lung diseases, risk factor, children. The underlying structural lung disease, risk factor children as well as adult. So the older PLHIV have the COPD, malignancy, all these are newer emerging risk factors because the ART people are living long. So we are able to find other comorbid like COPD, CCF, CRFR coming into picture. So next slide. So what is that clinical manifestation? Acute onset. Remember that here it is acute onset. Whereas in other conditions like TB and PCP, it will be subacute and chronic. So symptoms include fever, chills, rigors, chest pain or pleurisy. Cough is productive, virulent. Sometimes it could be blood strained. Then presence of fever, tachycardia, hypotension can be indicators of sepsis. So whenever there is a bacteremia and sepsis, there will be hypotension, tachycardia, high-grade fever. In children, same thing. Not able to take feeds, persistent vomiting, convulsions, poor sensorium, poor lethargic child. Stridor is an emergency, respiratory emergency. So this is in the children. So tachypnea, decreased hypoxemia, or very, very severe, denoting very, very severe pneumonia. So already I've told you respiratory rate like PCP, it's more than 60 means acute severe pneumonia in impending sepsis. So next slide. So this is the clinical manifestations of pneumonia. So in children, how cough and cold, no pneumonia, home advice, fast breathing, oral amoxicillin, and in drawing. So we can give home care advice and ask for parents for a red flag sign, educate them and ask them to bring back the child immediately if there is a red flag sign. General signs of serious severe pneumonia, patient has to get admitted immediately in a pediatric setup for IV antibiotic. Next slide. So these are all the serious pneumonias where you have to inpatient care. So recurrent bacterial pneumonia, current episode plus one or more previous episodes in the past 6 months, current episode plus one or more in the past, respiratory rate more than 30, hypoxia, cough with fast breathing. So recurrent pneumonia and signs of severity. So these are things we have to be taking care of. Next slide. So this is regarding the clinical presentation. So we all know to come to the diagnosis, the commonest pathogens are the Streptococcus pneumoniae and influenza pneumoniae, and rarely you can get the other atypical mycobacteriums like Legionella, Mycoplasma can come, and some other times Staphylococcus aureus. So microscopy will be gram staining, other thing. Culture can be there if there's so we can availability is there. Chest X-ray is a very important diagnostic tool. Total count you can be increased and you know the severity. And other comorbid you have to take care by AFB staining. Next slide. So this is regarding the diagnosis. So CD4 count, the differentiating DD between the PCP and bacterial pneumonia in that CD4 will be less in PCP, CD4 will be more in pneumonia. Symptoms is non-productive cough in PCP, whereas in pneumonia it will be high fever with purulent sputum pain. So symptom is subacute in PCP, acute in pneumonia. Signs are, you can get PCP very rare, whereas focal lung signs, the form of crepitations or tubular breathing, bronchial breathing will be there in the pneumonic consolidation. Total count usually elevated, neutrophilic leukocytosis. Whereas the distribution will be a diffuse in X-ray, whereas it is lobal or focal in a pneumonia. So location usually bilateral, Here it is unilateral or segmental, subsegmental. Pattern reticular, here consolidation with air bronchogram, tree-like pattern. Pleural effusion is very, very rare in PCP. Here in 1/3 of the pneumonia patients, there will be syndemonic or sympathetic pleural effusion. Next slide. So this is the differentiating presentation. So general condition usually 5 to 7 days, or it will be more. The radiological thing will get delayed. The clinical improvement will be seen immediately, but it will take 1 week time for the radiological dissolution. That you should keep in mind, clinicians. So longer duration of antibiotics are often required when severe pneumonia or bacteremia is present, particularly if it's streptococcal pneumonia or complicated aureus infection. Switch from IV to oral, step down. It will be continued when clinically improved after 5 to 7 days. Oral antibiotic for another 10 days or 2 weeks. Next slide. So these are the general conditions for pneumonia. Treatment protocol. So high dose amoxicillin or availability, whatever the available antibiotic in your region, with the microbiologist's advice or the senior physician's advice, you can start the treatment. Only thing you have to cover for the atypical mycobacterium, usually with azithromycin or sometimes with the quinolones. Even though you give high dose of amoxiclav, you have to cover for the atypical organisms, the second antibiotic. Next slide. And preferred therapy in a hospitalized non-severe cases, IV plus macrolide cover for atypical. All these are, availability. You can find out from your stores. And then children also same thing. And alternate therapies plus doxy to cover for atypical. Penicillin is even still now it is one of the wonderful drug, crystalline penicillin, IV. But only thing has to be given 3 to 4 times a day. And next slide. CP, that's called CP, crystalline penicillin. So patients severe pneumonia, all these are whatever the settings in your place, in your availability, you can judiciously use the antibiotic. Penicillin allergic patients can use IV carbamazepine plus IV respiratory quinolone. Next slide. So risk of pseudomonas pneumonia, it is a difficult pneumonia. We have to give a IV anti-pneumococcal, anti-pseudomonas beta-lactam, IV Cipro like that, along plus quinolone plus beta-lactam, then piperacillin tazobactam, all these 3rd generation, 4th generation antibiotics, or you can give anti-pseudomonal beta-lactam plus IV. So there are always 2 drugs covered for both organisms too. So patients at risk for MRSA, methicillin resistant Staphylococcus aureus. These are vancomycin. These are all selected centers. You can use it. Next slide. So these are the treatment protocol. So now we have finished the pneumonia where you have found out that it's acute onset. It is also like a big pneumonia is a respiratory emergency. Whenever a patient comes with an elderly person, HIV positive with a big pneumonia, they can go for impending respiratory failure. So we have to be very careful and immediately put him in the ICU and start a highest spectrum of antibiotic, and we have to actively place him on a chest physiotherapy, and immediate patient has to be on a physiotherapy and other things. So respiratory emergency, can you include a big pneumonia also in the respiratory emergency apart from PCP and pneumothorax and ARDS. So now we are coming to the Mycobacterium avium complex disease. This is a disease of exclusion, very low CD4 count. Next slide. So what will happen? Advanced HIV disease, usually disseminated disease through inhalation, ingestion or inoculation of MAC bacteria via gut or respiratory tract, less than 50 CD4 cells. So fever, night sweats, chills, weight loss, all these constitutional symptoms, hepatosplenomegaly, lymph nodes involvement, and MAC disease has to be clinical signs plus in advanced lab you have to find out and identify the MAC. So it requires a microbiology expertise. So blood culture, all these are very, very requiring more expertise. So routine prophylaxis for MAC is not recommended in India. Whereas in some of the developed countries, they give a clarithromycin or azithromycin prophylaxis till the CD4 goes beyond 100 or 200. So that was the prophylaxis not given in India. Next slide. So MAC is, what is the preferred therapy? So you have to exclude everything by CB naught also, it will not come positive. So you have to find out by a different mechanism, get the microbiologist interaction and find out the MAC, then it has to be usually given in a DRTB center. Anyhow, you can get a chest physician's opinion and start on a therapy of clarithromycin plus etombutol daily. And if you suspect a drug interaction, you can give azithromycin. And sometimes the third drug is usually given like a quinolone or rifabutin. For that minimum period of 12 months, sputum or culture becomes negative. Full 12 months treatment you have to give for the MAC, Mycobacterium avium intracellular complex. So MAC is a dreaded disease, but usually it is not easily found out by routine investigations. It is usually done by a exclusion, by excluding the other diseases. So MAC, we can give a treatment. Sometimes usually it occurs in a atypical occurs in a already damaged lung in the form of a bronchiectasis or in a cavitating places, nodules. It comes like sometimes nodules and cavity in a pulmonary setting. Next slide. So management of MAC we have found out. Now we are coming to the fungal infections of the lung. So fungal infections of the respiratory tract are common thing is penicillinosis. It is Northeast India. It is there, previously known as Penicillium marnifi. Now the name has been changed to Chaloromycosis. Next slide. So usually it occurs as a dimorphic fungus caused by Penicillium marnifi, geographically restricted to Northeast India. Subacute illness, fever, weight loss, hepatosplenomegaly, and GI disturbance. Skin lesions are very classical, like molluscum-like lesions, central necrotic papilla with umbilication, appearing on the face, trunk, or extremities. Next slide. So, history of, now this is the picture from the RIMS. Already this slide has been there for many years. We have to use it for teaching the junior colleagues. So this is the Penicillium marnifi or Chaloromycosis, cutaneous, manifest, just resembling a molluscum-like thing. Next slide. So this is cutaneous. Then pulmonary is shortness of breath. Diarrhea will be there in GI, CNS, meningoencephalitis, a rare presentation. Others, anemia, thrombocytopenia, AST elevation, ALT, the ratio of 2:1. These are all lab parameters. Next slide. So this is only geographical. So how to find out presentive? You have to use a GM-SA strain and aspirate for bone marrow or other things for this staining to find out the lesion fungus. So it's the histopathologic exam demonstration of the organism with biopsy specimen, PCR-based methods also there. Usually consider all patients HIV with the travel history. Next slide. So the travel history will be there. If you take a travel history, it will be there, the history of travel to the Northeast or the rampant place. So here amphotericin B you can give, or it can be given that levomer, the deoxycholate amphotericin can be given for 2 weeks, followed by itraconazole. So criteria for discontinuing maintenance therapy, CD4 more than 200 or 6 months in good response to ART. Next slide. So this is the prevention and management. So what are the other pulmonary manifestations? In a broad setting, we are going to see the other things. Next slide. So other fungal infections are histoplasmosis. So this is very rare, progressive disseminated histoplasmosis, presence of fever, fatigue, weight loss, and hepatosplenomegaly. So cough, chest pain as a pulmonary, then CNS, then GI will be there. Diagnosis, lymphocytic increase, elevated protein, low glucose. So just like cryptococcal. So histoplasma capsulatum can be cultured from the blood. Deduction of the antigen can be done in the early phase. And so induction therapy, liposomal amphotericin, maintenance itraconazole, same thing like a Penicillium marnifi. So just keep in mind histoplasmosis. Next slide. So what are the other things? Nocardia, very, very notorious. Nocardias is a branched filamentous organism. We have seen before the ART era, we have presented 7 cases in history, and our study was published in a journal, Nocardia in HIV setting. The most common presentation of chronic cough, chest pain, more pleuropulmonary involvement. You can see the X-ray, which was taken from Tambaram, where you can see both the bilaterally pleuroparenchymal involvement is there, and you can see the branched filamentous washings for Isolonocardia, classical branched filamentous, quinine acid phosphate reveals acid fast basilic branched filamentous. That is like a actinomycosis. Next slide. So this is nocardiasis. Treatment is cotrimoxazole, 6 months, and along with amikacin also. So aspergillus, another fungus, usually In a immunocompromised, it will be ABPA, Aspergillus myxoma in a TB patient. Cavity will grow a fungal ball. But the first two are not that, not very serious, where you get in a HIV negative individuals. These are all. But whereas the invasive aspergillosis comes in HIV, very serious, where you have high fever, pulmonary consolidation, hematogenous dissemination, fever, dyspnea, and the radiographic findings of thick-walled cavities, most commonly in the upper lobe mimicking tuberculosis. So amphotericin is the drug of choice, or you can do combination therapy. So this is voriconazole. It's now available. Very costly, but IV and oral. So you can give that and good results. So invasive aspergillosis in HIV is very life-threatening opportunistic infection. Next slide. So this is further a note on other fungal infection is the Cryptococcus neoformans. Previously, before AIT era, a lot of cryptococcal CM, cryptococcal meningitis, cryptococcal lung, all disseminated. Nowadays, it is present in the soil and it usually affects the HIV. Rarely it can affect the farmers, very rarely. So chronic or subacute can disseminate widely, and we can do a LP, even though a pneumonia is there, LP to exclude a concurrent cryptococcal, where India ink preparation, the famous India ink where used to do in a resource limited setting and find out the cryptococcal meningitis. So cryptococcal lung also, we have to keep in mind in a very low CD4 count. And also it can also come as a cutaneous presentation, rarely. Cryptococcoma in a, like a molluscum or a penicillium monographine. Next slide. So other fungal infection is cryptococcus. So COVID-19, now we have come to another 5 minutes. We have to fast rush up this thing. All this you are all aware. The COVID-19 era, 2 years. But fortunately, we have seen, I don't know, you have to give your inputs. That was not different from the normal population. Whatever the mortality, morbidities, like the general same thing, only obesity, old age, other comorbid conditions. So HIV alone was not a big, not had a big impact. But you can, I want the colleagues' feedback on that. So what are that? Liver, renal, pulmonary. Pulmonary is what we are interested in: pneumonia, acute respiratory, and respiratory failure. Headache is there, seizures are there, ocular, dermatologic, so many things. Arrhythmia, sudden myocarditis, on this hypercoagulation, everything we had, and we have gone through a 2.5 years of traumatic phase and come out, I think, successfully. Next slide. So this is multiple system immune COVID-19 in HIV. Next slide. So what happens? So mild disease, upper respiratory tract without shortness of breath. Then the moderate disease, respiratory more, SpO2 of 90, less than 93. Then comes the severe disease. So we have to go to like ART center, COVID care center, COVID ICU, and they have to be managed there, whatever non-HIV or HIV, PLHIV. Next slide. So COVID was there, and risk factors: severe disease, mortal population more than 60 years, cardiovascular disease, diabetes, chronic lung, all this, the general population only. Not all these were not something which is unique to the HIV patients. Next slide. So risk factors are like the general. So what are the other OA complications other than the infection? What we have to keep in mind. See, we are having an aging HIV population, maybe ex-smokers. So COPD is there. COPD, acute exacerbation, come in a HIV patient. So that is the non-infectious complication. Then primary pulmonary hypertension in HIV. HIV patients are prone for more primary pulmonary hypertension. Then you have to give all this sildenafil citrate, boventon, all this. It is in a advanced setting where you have to give them a continuous supply of pulmonary hypertension drugs. Then the LIP, interstitial pneumonia, lymphoid interstitial pneumonia, which is a rare form of a non-infectious disease where you are getting a what is that you get in a lymphoid? Progressive death, breathlessness, fever, and pediatric, it is common. LIP, HRCT, chest will show nodular infiltrates, reticular PFT will be restrictive, and HPV, histiocytic plasma infiltrates. That is the LIP you have to see, and steroids you can give. Then malignancy. So the lung malignancies are more common in HIV, CA lung. Then you can have a primary effusion lymphoma. Then we have this Kaposi sarcoma. Then all these lymphoma, non-Hodgkin's, all this can come as a presentation in the lung also, and CA bronchus. Then bronchiectasis. Whenever there is a bronchiectasis, or it could be due to repeated infection. A patient, a HIV patient can develop a bronchiectasis. Next slide. So what is the other thing we have to see? The next slide. So what are the carry-on points in a pulmonary complication? HIV depend on the underlying host immunodeficiency. So you have to find out, apart from the HIV, whether they are having a diabetes mellitus or a CRF or a what is that? They have any other bronchiectasis or COPD. So exposure to potential pathogens, whether work history, occupational history, whether they are exposed to any pathogens, whether they are exposed to any carcinogens to rule out a CL lung, whether any occupational lung disease coexisted with the child. So the exposure to this one. And also history of travel. Already in Northeast, you can get penicillium marnefate. So histoplasma, all these history of travel, these things are important. Pathologic virulence of the organism. Now you know the influenza virus is there now. H3N2, but it's not that virulent. So we are all getting a viral mild infection and go away. But some of them are landing in ICU. So the vigilance of the existing organism is also an important factor in treatment. And the microbial susceptibility, whether they are drug sensitive or drug resistant. And what is the chemoprophylaxis? We have the PCP prophylaxis, we have the TB prophylaxis, and as well as secondary prophylaxis with the fluconazole, streptococcal meningitis. All now this become rare. And the vaccination is very, very important. We have the influenza vaccine. We have to give every year. When the CD4 is more than 200, boldly can give if it is available or affordable, influenza vaccine every year to prevent morbidity and mortality. Pneumococcal vaccine to prevent bacterial pneumonia. Prevenar, like that. Sorry, we should not name the trade name. So it is a pneumococcal polyvalent antigen pneumococcal vaccine once in 5 years. So all these are newer things which have come. Shingles vaccine, all these are there. If the resources are there, we can use that. Smoking. So important thing is cessation of smoking. That is very, very important. We should go about it and see to that they stop smoking so that the morbidity to the lung is reduced. And I think we have come to the end of the slide. Next slide. So any other queries are there, we will try to solve it. So CMV. So the other thing I forgot, the cytomegalovirus, the viral infection, very, very low CD4 count, dyspnea on exertion, non-productive cough, hypoxemia, diagnosis by exclusion. Ball study will show inclusion body of CMV, CD4 very low. Now for completion, influenza virus, H3N2 now prevailing. So annual vaccination to be done for influenza. I think we come to the end of the slide. Next slide. I think if, thank you very much for your patient listening. We will go to the chat box and Sweta, can you help me?
Yes, sir. Yes, sir. Just give me 2 minutes, sir.
Yeah.
Participants can type their questions in the chat box or they can even unmute their mic. So there's one question in the chat box. What's your opinion on doing urine histo testing? If it's positive, is an X-ray is normal, is the mode treatment the same?
Urine histoplasmosis. If it is positive, I don't know, because we have not treated much of histoplasm. But anyhow, the urine tests are there. If it is positive, but the X-ray is normal, we have to go about the symptom. Maybe it is a, we don't know the impact of treatment. Or you can give the treatment benefit of doubt to the patient, you can give that. No harm. But only thing you have to closely monitor the patient and see for other constitutional symptoms and do that. But personally, I'm maybe some of our friends can help in that. Before that, there is another question: role of IPT as secondary prophylaxis. Usually, IPT as a secondary prophylaxis. Usually, I don't think there is a role for that. We have to follow up the patient up to 2 years, and then 4 years is there. We have to see for the active tuberculosis and treat the patient. I don't think there is any role of IPT as a secondary prophylaxis. No.
So any other questions?
Person wants to comment on the histo testing urine with no X-rays normal. Or I think we can, if you go to our HIV-21 that guidelines, I think there is a good chapter on the histoplasma. We can go and see that, and we can get the opinion from the experts.
So your audio is cracking a bit.
Yeah.
Any more questions from the participants? Please feel free to unmute your mic. So I don't think there are any questions. Can I quickly run the feedback poll, please?
Yes.
The feedback poll is now visible on your screen. Participants are requested to please scroll through all the 4 questions and answer them. Requesting all the participants to please attempt the feedback poll. Thank you so much, sir, for facilitating this session.
Thank you very much, Sweta. And thank you, participants, for your patient listening. All the best.
Thank you, sir. So can we conclude this session now? Thank you to all the participants. The next session, please give me a minute. The next session is on 5th of April, and the topic is HIV and opportunistic infections, gastrointestinal system. For that, you can refer to chapter number 4.4 of the National Guidelines for HIV care and treatment. Tomorrow, we have a NDLS session on SASEP. Please join us at 2 p.m. Thank you, everyone. So we'll end the session now. Thank you.
Yes, ma'am. Thank you.